Welcome, everyone. Grand Rounds time. I'm going to introduce you to Dr. Kari Stevens, who's PhD. She's a practicing clinical psychologist, clinical researcher, and biomedical informaticist. She has over a decade of experience in biomedical health informatics and information technology. Her research currently focuses on two areas: disseminating evidence-based behavioral practices into medical settings, and developing data sharing methods and tools to leverage electronic health data for research. She has received research funding from numerous federal and private agencies, including the American Psychological Association, Society for Public Health Education, Center for Disease Control and Prevention, Department of Defense, and National Institutes of Health. She actively collaborates with the Division of Integrated Care and Public Health, the Institute of Translational Health Sciences, the eScience Institute, and the DARTnet Institute. Dr. Stevens.
Thank you. Hi, everyone. Or as Jürgen says, I do way too many things. I need to do less. All right, so I am terrible at coming up with titles, and this one is a horrible title, Leveraging Electronic Health Data to Improve Health. This is a snoozer title. I think, really it's more about electronic health data. Why do I care? It's kind of my goal here today to hopefully reach out to you guys and make this very consumable and something that you'll be excited about by the end. Imagine being excited about data. So first I want to start with a quick little story of a health journalist who came up to me at an eScience Institute event, and she said, you got to quit using the word data in all of your stuff, because I can guarantee you if you had focus group room and you put words on the table and one of them had the word data on it, no one would sit at that table. And it just sort of hit me of going, what do you mean? For the last 20 years, data has been my life. So to bring it down to earth, I thought I would give you a metaphor to start this with. So I have 3 children. And my sons are obsessed with Legos. So this is a picture I went and snapped in his room of his collection of Legos. And to me, it looks like a mess, right? A mess of just ridiculous stuff that I have no idea what you could possibly do out of this. And to me, this is the problem. This is very analogous to data for us. There is a big pile of mess of stuff that we have out there. Many of us don't know what to do with it, don't have tools to use it. But what's exciting to me is when you have the right tools. This is my son, he's 11, is, you can start to build stuff. So he comes in and goes, Mom, hey, check this out. I built a katana. And just, for all those of you out there, he's a little obsessed with weaponry. So he wields this at me and says, oh, but look what I made next. I've actually got this Desert Eagle, this pistol. But what's great about it is Dad can't hold it because it's sized perfectly to my hand, which is awesome. And then he put a little rubber band in there, and the trigger actually feels like a trigger, which is just horrifying to me, where I'm going, stop pointing that at me, even though I know it's Legos. And he says, that's not enough, right? I need a tactical knife to go with it, right? And this goes on, and to the point where he builds this unbelievable MP7 that is fantastically awesome. It has this piece that comes down in the front. It sits off his shoulder. You can't tell, but that shoulder piece actually pushes in and out, and there's a magazine clip at the bottom that actually functions, right? So I'm looking at this going, all right, data. Could you dream that these are the kinds of things you could do with Legos if you bought, your niece, your nephew, your grandkid, your child, whoever, a box of Legos? You don't really know what they could do with that, but they do when they've got the right tools, right? So big data, I think this is a term that's getting more and more popular out there. We're all hearing about it. We're all interacting with it actually all the time. For any of you who bought an airplane ticket. What is it? I think the way that we describe big data is through 3 terms. It either has a ton of volume, or it has a high rate of kind of happening, like in the ICU, where you're taking breathing status over and over and over and over, or it's really complex, which is really in healthcare where we are. It's just incredibly complex. And so at this point, I want to start to answer to some degree, why is this important now? Because we've had big data pretty much since supercomputing began, close to 100 years ago now. So really, the issue is that now it's affordable. We really can store tons and tons of data. Disk is getting cheaper and cheaper every day. We've figured out the cloud and how to push things out into spaces where you can just grow farms of servers. We also are collecting it everywhere. It's constantly getting generated and digitized in all kinds of ways. And then we can start to transport it. You know, with the internet, when I first started with all this at Children's Hospital, we were just starting to install internet actual accessibility to the research offices. So, but now, you know, we can access data all over the world. When I went to Congo recently with Deb Kaysen, and we were doing CPT training there, I was accessing the internet in a hotel in Bukavu in Congo, which was insane to me. But the problem is we're completely buried. We have no way to kind of sift through this massive mountain of information. And so there was a guy at Microsoft named Jim Gray, and the folks at Microsoft Research put together a book called The Fourth Paradigm. And they really are talking about the evolution of where data science has come to. And so if you think about this 1,000 years ago, really that's when we began sort of empirically describing things. Instead of saying the moon is rising because the gods put it there, we started to go, it's kind of doing that every day, and it's phasing over time, and what's going on? And we started to describe that. You know, that was really the first paradigm we had. In the last few hundred years, it became theoretical, where we started to hypothesize, where we started to discover things like maybe actually it's not the moon moving or the sun moving, maybe we're moving, or maybe the moon is moving, but we're moving too. And then how does that work, right? So we started to have new theories about this. And in the last few decades, we had supercomputing come into being. You know, and we didn't know what any of this was going to do for us. Nobody sat around and said, when we build supercomputers, we're going to predict weather. That's why we want to do it. We just built the computers, put them in place, and things started to evolve. At this point, we call this now the fourth paradigm, where we're in now, where we really need to come into the world of e-science, where we need to do data exploration, where we need to take theory and experiment and simulate what we have out there. Okay, so this is just by way of background for you all on the geeky data side. In terms of bringing it to healthcare, the Institute of Medicine has been talking about the learning healthcare system since about 2007, where they first put out their report saying, you know, we really need to figure out how to create this unbelievably fantastic idealistic loop, right, where we have the researchers and we have the clinicians and we have the patients, and we're learning constantly as we go and iterating over time. You know, and one of the things they said is that you have to get the right care to people when they need it, and then capture the results for improvement, and so on and so forth. One of the things that they described, among the 10 needs that they specifically said were needed for this, were tools for database linkage, mining, and use. So they knew that this is something that we really have to accomplish in a good way. So all of us are kind of moving towards that. The problem is, depending on how you look at it, it's been claimed that we're underutilizing these data massively. We really are not using very well at all everything that we collect. We now have the meaningful use in place. For those of you who don't know what that is, this is a mandate out of the High-Tech Act in 2009, where we now have to comply with meaningful use if we want to get more money from Medicare. And everybody wants to get more money from Medicare. So even the small practices that might not take Medicare are playing to meaningful use because the other practices are, and they're going to model after them. Meaningful use means you have to meaningfully use your electronic health record systems in various ways. So it's having a huge impact. In addition to that, depending on how you slice and dice it, you can say certainly millions, but probably actually billions of dollars at this point are going into trying to create these data infrastructures across the country. I've put 3 up here that are kind of big ones that are currently going on. One is in the NIH Collaboratory, where they've got a distributed research network and development. And that the NIH is really looking to take pragmatic trials to the forefront and create methodology to create resources for researchers to do these kind of pragmatic trials, which is really exciting, different kinds of methods. And all of these pragmatic trials are using electronic health data in various ways. Doug sitting here is doing one of these. We've got 4 of them actually right out of the Seattle area. There's only really about a dozen of them, so we kind of have the lion's share of those projects. But they're all nationally involved across the country. PCORnet, the PCORI Institute, is also funding something called PCORnet, which right now includes 11 clinical data repository networks. And we're up for 2 of those and joining 2 of those in this fall, which we anticipate high likelihood we'll get those. And what they're doing is requiring that each of those clinical data repository networks have 1 million+ patient lives involved in that system of care. And they need to be comprehensive systems, so specialty care, ambulatory care, hospital care, and have claims data. They want the whole shebang. They want all those data kind of synergized, harmonized is the big word in the field now, so that we can pull them out for various reasons. In addition to this, there's Big Data to Knowledge, which is the BD2K initiative that NIH is also funding. So this is their mechanism by which they're now funding a whole bunch of these cool projects. So lots is happening in this area. So in terms of background, that's just kind of hopefully in some ways get you excited about what kind of katana maybe we'll make, okay, together, hopefully non-violently. If I bring us back locally here at UW-Medicine, I started in information technology in 1996, working here at UW-Medicine. And so I wanted to give you some history from my journey here through my research career of how I sort of approached to trying to make better tools for us in this big piling of data that we have going on. So in UW-Medicine, we had a Sherilyn Fuller, who's in library sciences, got a grant from the national, the NLM, the National Library Medicine, something like that, NLM, one of the institutes at NIH, an IANS grant. And it was focused on being able to bring library resources together with electronic health data resources, because we had all of these different systems of care going on within the hospital. And this bubble kind of picture over here on the left is, the patient was getting touched by all of these different data systems that were all generating tons of data that also could be helped by the library. The good news of all this is that it caused us to create this thing called MIND, which was the Medical Information Network database. And what it was is a compilation of all of these different data sources together in one place. So we went to Lab Medicine, who was very territorial about their data, and said, no way. And we said, come on, you can put your data in this way, and this is how we'll do it. So when I was speccing out the lab interface for that, at that point, creating this database, there was a lot of negotiation on the governance side, and I'll talk more about that. But even within our own little institution, we had to agree to do this. But the good news is we did, and we created this great database. I was the data design architect for it. And one of the things that we did, one of the very first tools that we built, there's a small handful of us that were developers, is we built Mindscape. And I'm guessing a bunch of you know what this tool is. And in fact, it still exists today. So on the suggestion of Eric Larson, he said back then he was our medical director at UWMC before he was at Group Health. And he said, you guys, we should, send something into the Lancet. And what did I know back then? I said, okay, that sounds like a good idea. And so we put this little article together, and, because it turns out Mindscape was the very first electronic medical record that was web-based ever. And this was before we had vendor systems that were doing this kind of thing. So it was very exciting. We did this systematically with pilots. We started out, I think, with 40-some users. We then moved to 600-some users. And the good news today is we've got thousands of users, and I just thought this was fun to give you a little screenshot. This is a test patient, so don't worry about identifying information, but this is my view of Epic. I attend in the pain clinic and see patients on Thursdays, and I go in and I can go to Mindscape and still see it. There it is, still old as ever. We quit developing it many years ago. It was supposed to get retired, but it works. People like it, and so it's still there. It's been this massive success, but one of the issues with it was at the time, well, this is great for all our internal people, but what about the outside people? At the time, I was doing a lot of work with our physician liaison program. I was working with marketing and quality improvement, and we really wanted those referring physicians to feel like they were getting good service, and one of their big complaints was snail mail was horrible. Somebody comes in, they get a great cardiology procedure, or someone comes in and Airlift Northwest brings them into Harborview, and they come back to the community and they have no idea how to do wound care. Because they're waiting in snail mail for that discharge note to understand what to do. And I said, you guys, we can just give them access to Mindscape. It wouldn't be that hard. We just need to figure out what their patients are. And they said, oh, really? How do we do that? So we just wrote up a security module, and my favorite programmer came back to me in the afternoon after I wrote a 10-page spec on how security-wise you had to do this, and he handed me 4 lines of code and said, read that over and tell me, does that do it? And I said an hour later, after kind of reading 4 lines of code for an hour, yeah, it begrudgingly, which was, to me, the fun of this. This is my self-proclaimed geekiness. And so the best story, though, that goes with ULink for me is a few years ago when we were doing this data connectivity project that I'll talk to you about in a sec. I was out at one of the tribes, and part of working with tribes is telling stories, and I needed to tell my story of how I came to there, and this piece came up. And they stopped in their tracks, and they stopped the entire conversation and said, you built ULink, which I felt like, well, I helped build ULink. But, and I got this just unbelievable thank you. And I got told how many people in their community that I helped because we had built this thing. And so it just came full circle for me of going, right, that's why we do this, not just because it was fun and we did 4 lines of code that actually pulled it off, right? All right, so we learn lessons from this, right? Is that you have to bring various domains of data together. This is important. And you have to make the data useful. And what I mean by that is if you bring all the data together, but you don't have some purpose for using it, what is the point? And then these things go away. But if you pull something together like a powerful tool like Mindscape that is using the data, Mind has still not been retired. And our IT group has tried to retire it for many, many years now. And because it's become so useful and critical for people, it's not. So you need that sustainability side. The next tool that we built was something we called MAP, which is the Mind Access Project. It was about, so that's great, you've got Mindscape, you've got Ulink, you can now look at data one patient at a time. What if I want a bulk of patients? What if I want to get a data set from people? This is what our marketing people wanted. They wanted to benchmark us to this old group. I still remember the very first extract they asked me to do. The Picker Institute is who we used to hire to do that and see how our hospitals matched up. And I ran that query to put those data together. So they wanted something they could do that automatically with. This was a fabulous tool. It was a website. You could go to it. You could query whatever you wanted. You could query anytime you wanted. It had a dictionary that I kept up to date that people were looking at. So it said, if you want death codes, you know, there's the expired patient flag here. But really, if you really want dead people, you need to go here and here. And so people got savvy using it by reading through this dictionary posted up there. And then HIPAA came along. And we had to shut down the whole thing, which really sucked. I mean, it was a fantastic tool, but it also needed to be in compliance. There wasn't enough auditing. There wasn't enough what we call honest brokerage going on for those data sets, which is really important. So now, today, the Institute of Translational Health Sciences, the ITHS, for those of you who don't know, is an institute here at the UW, funded by NCATS at NIH. And they have put together the De-Identified Clinical Data Repository. Horribly named. I'm not the only one who's bad at naming. But you can go to the ITHS website, and find the DCDR and potentially get your own login to the system and do counts. Okay, you can't get the whole bulk of the data set, but you can do counts of patients on the fly with this tool. So it's pretty cool. So the good news is we still have some ability to go in and do that in a way. It's not totally hurdle free because you have to do sort of their login requirement sort of pieces. And again, you can figure that all out online just walking through it. The bad news is we've gone kind of backwards here, right, with all of this. But the better news of it all is that this is a tool that lots of other institutions are using. And so now we can start to actually network much beyond ourselves in this region. Okay, so lessons learned, right? We're building here. So we have to give out data in bulk and efficiently. And the technology has to support privacy regulations. You can build a great tool, but if it's not HIPAA compliant, and in fairness to us, we built the tool before HIPAA. So when HIPAA came along, that's when we got shut down. All right. I moved from IT to psychology, really, and went back and became a clinical psychologist and did training along the way as I sort of left that arena to some degree to go do that clinical training. I wanted to use the data I knew so much about for meaningful research, and I came here as a resident. And I had the good fortune of working with Doug Zatzik when I was on residency, and we wrote a diversity supplement together to work on his R01, where he was doing a collaborative trial in the acute care setting on PTSD. And I thought, this is a great opportunity. I can start to figure out how can I leverage all of these huge, rich data sets and start to answer, to me, some meaningful questions around diversity, around disparities in care and disparities in post-traumatic stress disorder. And for me, learn much more about PTSD. So we did a study, and we looked at leveraging the trauma registry, which, I pulled this Doug out of the College of Surgeons, who said all about, trauma registries need to exist at these level 1 trauma centers in the country. And here's one little reason why, because if you have them, you can do this really kind of great research. Doug's team was also going around and screening all of these patients for this trial. So we wound up with an N of 623 patients. For me, this was a huge shift to look at, and I'm not going to get a ton into the content of the results of the study, except to say that there are disparities in post-traumatic stress across different racial groups. I think a lot of us know that. But what was exciting to me is that I'd come from a place of doing a lot of randomized control trials. I did several of these through graduate school. The ends in those are 50 people, maybe 100 people. And who are you touching with these interventions when you're doing it, and is there dissemination, and how do you really know you've got who you think you've got, right? And so to me it was very exciting to be able to kind of push myself into these systems that exist now as a clinical researcher. We did another study, you know, as we found, okay, so there's disparities in post-traumatic stress itself, but are there disparities in care along the way as well? And we did a quick study just looking at length of stay in the hospital and found very alarmingly, actually, there's a really big disparity. So for those of you working over here at Harborview, patients that are admitted for some kind of traumatic injury that meet qualifications to get put into the trauma registry have quite big disparities in care in terms of length of stay, and we don't know why. We controlled for all kinds of things. I think Peter Royburn said maybe it's a insurance interaction kind of piece. You know, it's a great idea. Nope. You know, that didn't pan out either. So for some reason, people of color do not stay in the hospital as long as people who are white, and they're missing out on that care, and we don't know why. So lessons learned, kind of pulling me back again. So registries are great, but they're missing key variables. So I was lucky enough to have Doug's team who had gone and meticulously collected race, for example. We have horrible race data in these electronic health record systems. His team had also collected some patient-reported outcomes. So we could actually mirror that with what we had in the registry, which was great. Along the way, while I was doing this work over in acute care, I was working with Jürgen as well over in the ambulatory care arena, in primary care. Because collaborative care, is this amazing thing that all of us hear a lot about because we've got so many great researchers here working in that area. So we had this county program that was going in King and Pierce County that then expanded to the state that I was working with, and that's now called MHIP. And a lot of you have heard Jürgen talk about that program and the tool that he uses, that registry tool. So I came on board and he asked me to help improve that tool. And part of what I did along the way was go and work with a bunch of the behavioral health specialists to find out how they're using it. In my mind, they're the users from a technical perspective. As a psychologist, they're the front line who are doing this work. It's a fabulous tool. One of the big issues with it several years ago is that the way that the data were being stored was not scalable for any kind of big research. So that was one of the first things I said back to their team, and they listened very well, and they revamped their entire database in good ways so that now you can pull data out in a better way. And it's another registry tool that's now got over 50,000 patients in a great way that has a whole bunch of information around patient-reported outcomes. So one of the things we wanted to know is, in looking at that kind of a data set, do patients who have post-traumatic stress get well engaged in care? And do they get better? And so this is just really a descriptive study. It's really messy data. This is real world, messy data. But if you look in the red box, and I'm sorry the numbers are so tiny, but you can see that basically what we did is we took patients in this system who had some measure of the PCL, which is the standard tool for measuring post-traumatic stress, and said if we split that across kind of mild, medium, and severe symptomatology, what we found, if you kind of, in the field of data, we call it data provenance, which means what does the data really mean? Where did it come from? The behavioral health specialists, what they're doing is they're using the PCL for those patients they suspect have PTSD. So this is a convenient sample of patients that likely are suffering with post-traumatic stress. Otherwise, they don't really use this tool on a regular basis. So when we did that and we looked at this kind of special cohort, we found that in fact it did matter. I mean, if you had lower post-traumatic stress at baseline, you got less better on the PHQ and the GAD-7 as the two measures, right? And depression symptomatology and general anxiety symptomatology over time. We didn't have set windows of care. We just took whatever they did. Whenever they came in and whenever they finished, did they tend to get better. These are percentages up here. So you can see in that first column, people that were lower on the PCL basically, who had less post-traumatic stress starting out, got close to the 50% mark. About 50% of those patients tended to clinically get better, at least according to these scales. And that dropped significantly down to more like 22% if you had severe symptomatology. So, what that's telling me is we're not doing good enough care. We need to figure out a better way to treat these folks. The good news at the top of this table is that the patients who have post-traumatic stress do engage care pretty evenly, whether it's severe or not. And that was a question that we really wondered about. Are those the folks that are really avoidant? They're not going to come in, but they actually do. So that was exciting. A problem with this is there's no linkage to any of this registry data, kind of going back to the data again, to the electronic health record. So I don't really know if this cohort is the true denominator. I have no idea who the people really are in the clinics who have PTSD, right? Or if they dropped out before they even saw the care manager. So we need that better linkage. Along the way, for me, one of the other gaps that I was noticing in working with these primary care clinics was the fact that the behavioral health specialists felt very unarmed, meaning they felt like they did not know what to do with these patients. And again, as a clinical psychologist, the way I take that is they need evidence-based practices. They need to know how to behaviorally treat some of these difficult patients. So I worked on a training program developing this with various of my illustrious colleagues who are great experts in their fields. So Kate Comtois, Christopher Dunn, Christopher Martell, along the way, putting together different modules of training for these folks to see if, when we give them a brief training in some of these evidence-based practices, if this helps things. Some of the evaluation work we did was just very on the fly. This was all contractual training work that we did in collaboration with Community Health Plan of Washington. This is not a research study of any kind, but I'm still wanting to measure things because I'm a psychologist and I can't help it. And I want to know, does this work? Does this do anything? So I did ask them, are you increasing use of this skill? And I asked them, are you using the skill, and tell me how? And we did a little bit of coding on that to see, at least were they self-reporting the right kind of skill, as a sort of proxy of fidelity, which probably isn't really, it's nothing close to fidelity, but it was the best we could do. And by and large, they were doing well with that. But again, going back to the data side of it, what if I could connect this to the patient outcomes? What if I could actually look at, for all the care managers, I trained over 100 of these folks, if I could look at pre-post from when they did training with me and figure out how they actually dealt with their patient population before and after, wouldn't that be great? So the kinds of things, we can dream, and I could build my katana if I could have this stuff kind of connected. So the data sources need to be accessible, and they need to be linkable. And to some degree, we're making headway in that with these small registries. So let me kind of shift here for a sec and talk to you about what I've been doing with the Institute of Translational Health Sciences, given all these lessons that we've learned. The de facto system of primary care for mental health, right, is the reality that we're dealing with. And I think collaborative care is so exciting to me. There's this ability to reach tremendously the population. But as a tool maker and a data person, I'm also kind of looking at the bigger view of not just mental health to some degree. And so what we've been working on in the ITHS is how can we build pathways into all the data that's in primary care and really build research happening in those spaces. And that's when really this Data Quest was born. Okay, Data Quest is a project that I run with the ITHS that we basically call this powerful evolving infrastructure. It's very fancy language that we sat around and did strategic planning to create, that harnesses the health data of patients served in diverse primary care settings. It's easy to use, and it's used by many to improve health. Right? This is our goal. This is our vision for this. And so basically, you've got each individual clinic has their own EHR out in the world. And we work in the region. The ITHS, just like the School of Medicine here, serves the 5-state WWAMI region. And so we're working with the WWAMI Practice and Research Network, which is a network that is a practice-based research network that Family Medicine runs with Laura Baldwin as their director, and she and I collaborate on all this. This is the data connectivity for the WPRN. This is how we go and conduct research within that practice-based network by connecting the data to do great work. So the other piece, in the story I told you earlier, when I was out at one of the tribes, was actually working with Deidre Buchwald's group, who's working on the Native American Clinical Research Network. And they've grown now to 20 tribal communities. And we've data connected with one of those, and we've trialed actually networking with a few others. And as you can imagine, it is quite difficult. And most of it comes down to governance-related issues with Indian Health Services, sadly. But the WPRN is thriving in terms of governance and being able to move forward with a lot of this data sharing. And so we're hoping that the WPRN will really be this wonderful success that we can then hopefully bring the tribes into as we move forward. Okay, so along the way, we were having to figure out what the architecture was. And this is, I promise, as technical of a drawing as I'll get today. And basically, the takeaway I want you to have from this is that we're trying to embed a natural feedback loop in this system here, right? So you've got the EHR, the EMR here, and then you've got our clinical repository that we've pulled out based on this, and we want this to kind of be feeding back and forth. Again, going back to the learning healthcare system, you want to be able to, if you find a problem in the data set, go back and fix it. And so a lot of what we did was kind of figure out how to build that feedback loop into what we have. Along the way, I'm just going to kind of tell you the quick story of the things that we ran into. We had a lot of troubles. There was a huge diversity of organizations. They were rapidly changing constantly their technologies. Oh, by the way, we're going to be moving to a new EHR. in the next 6 months, and we won't be able to talk to you during that time at all because we're going to be completely and utterly buried in that transition. So we constantly are moving with this I guess, reacting to this moving target. And then they have massively limited resources. They don't have IT people at these clinics. We're working with rural-facing clinics that are serving disadvantaged populations. These are all community health clinics that are in our region. So we had to come up with a lot of strategies to kind of meet through that. We also were trying to figure out governance along the way, which is huge. So I've gotten to meet the Assistant Attorney General of the UW. I've gotten to work with John Slattery's office. I've gotten to work with the lawyers with the dean's office, and through all of this, we get all the right paperwork. It's unbelievably consuming to figure out, but we have figured it out. It's awesome. We have all of this governance in place now for any of you who are researchers to be able to come in and work efficiently with this system. So the good news of all this is it's working, it's succeeding. We've been at this for a few years. We've got a bunch of research projects using and operating within our system. I just gave you some examples of what some of those are right now. But you can see, and I put behavioral health at the top because those are the ones I like the most in those projects. But we hit all kinds of topic areas. It's primary care, right? So chronic kidney disease, colorectal cancer screening, lung cancer, you name it, we do it. And we're constantly putting in new grants. We have there's a couple of PCORI grants that are the behavioral health focused $10 million PCORI piece that are both potentially going to use this network. I don't think both will get funded, but hopefully at least one of them will. We've got a hypertension grant right now in review. We've got a bunch of different networks that we're trying to join in with as well that are looking pretty promising. So we actually did get added to the clinical trials network with the ADAI, which is very exciting, so that we can help support some of that research too. Okay, so one of the problems that we have, and this is sort of my current baby that I'm working on, is that researchers, when they say, okay, now I hopefully sold to you guys, right? I've got this data network, we've got all these great partnerships. If you want to do research with these practices, you can. I even got the governance figured out, right? Well, the first thing a researcher asks me is, yeah, okay, so and what data do you have? And I go, oh, how much time do you have? And so we need a way for researchers to be able to come on their own and look at that. And so we started hatching this plan for this idea a couple years ago for the Find It tool. And so, aptly named, Come and Find It. And so we created this website. And really, we were trying to figure out how, again, to get it into the hands of researchers where you can go in and you can look and see what are the data elements. And I'm going back to my map days, right, of going, there was this great data dictionary, right, before HIPAA came along, and people could go in and they could really look at what you actually had. Can't we just do that again? And so we whipped together this prototype. And this was kind of under the wire, as a lot of our research is done, right? This is not my initial primary mandate. This was kind of the thing that I snuck in along the way. And so once we had that prototype, though, the good news is the Institute of Translational Health Sciences decided to put a pot of money aside to support some innovative projects. And they asked us to propose innovative projects, and this was one that I won. And so I said, well, we've got this prototype, but it sucks. We need to have a good prototype. We need to have good methodology behind building this the right way. It could be, hugely scalable to all our other networks. It could really help researchers do their job better. And to me, again, it's about that creativity. You go back to the Legos. It's about what you could dream of if you knew you had those data. I remember this sitting, Doug, with you back in 2008 when we sat there and we said, well, let's just look at the fields they've got in the registry. What could we think of we could ask if we knew we had those data? Right, so we need people to be able to dream in that way and think creatively about their research. So when that was funded, we decided, in addition to kind of putting together a more structured warehouse and putting better services behind it, to also create Find It 2.0. And so we're in this human-centered design process, which I just love. And we have this fabulous department here, Human-Centered Design and Engineering, in our engineering school, that does a lot of this wonderful work. And we've conducted several user assessment studies. Many of you actually have been called upon to be in these for my studies, to figure out what do you need as a researcher. We need to ask you guys that. We need to stop thinking we know what you think you need and ask and see what plays right. So as we're doing that, I have this smattering picture of all kinds of folks. Ben Wilfond, who's a bioethicist. We've got Patrick Haggerty, who's a biostatistician. I've got students, postdocs, computer scientists. I've even got someone from communication who's working with the eScience Institute. I've got family medicine physicians in here. This whole team is what we call our design studio. And they meet once a month, once every other month, where we iterate the designs that we're doing with them and get this diverse set of perspectives, which has been really fun. So as we're doing this, we're going to be launching a new website in mid-September that's going to hopefully meet users' needs much better. Along the way with DataQuest, I think, just where we're heading next is local growth. We're going to be doubling in size in the next year because we've just gotten a whole bunch of grants that are fantastic. We're also going to be moving into more national growth, where we already have a very big, strong partnership with the Dartmouth Institute. In fact, in full disclosure, I'm an elected member of their board of directors, although it's totally voluntary. And they're this really lovely learning community of practice-based research networks around the country, and they have a whole data sharing infrastructure that we are very much in sync with. We're looking at joining PCORNet, and we're looking at the Institute of Translational Health Sciences isn't the only one of its kind. It's one of 63 in the country, and they're called CTSAs, and they're in schools of medicine. And they're institutes that promote research and hopefully helping people do research better and faster. So we're looking at crossing those CTSAs by having our network even more integrated. And then the last part in terms of next steps is I just talked about electronic health record data. That's all that's in there right now. But what about claims data? What about patient-reported outcomes? What about this huge field of mHealth that's growing, right? Wearables, actigraphy, the kinds of things that we need to be collecting. So those are next. We need to start laying the tracks down now for how we're going to architecturally put those things together. So I'm working with clinical research informatics here to try to figure that out. Okay, moving kind of towards to the end here, you guys. Leveraging eHealth data, right? There's a couple of institutes here that are working in this space that I just wanted to make sure you guys were aware of. The ITHS, I think most of you probably know. The eScience Institute is another institute here, and I'm on their steering committee, which I just am flabbergasted that I get to be, because they're really this innovative, fabulous group it comes out of the provost's office, and they just won a $40 million More in Sloan Award that's in partnership with Berkeley and NYU, and they're pioneering data science across the country in academia, and they're thought to be the thought leaders. And I want you guys to know that here, just to be aware that this is going on right here under our noses. And it's very exciting because the trends in big data science are really around machine learning and data visualization. We also have one of the top data visualization thinkers in the country here as well, and he's created a whole open source platform for how to do data visualization. So we need to take advantage of these great resources. I want to make a plug for, have you guys heard of data visualization? I don't know if that's something, some of you are nodding, not really. This term, what it means is, basically if you take really complex stuff, you make it consumable, So I just put up a smattering of pictures here, and I'm gonna just jump over, I hope this works here, to this website, because I just met with so Jeff here is the computer science programmer who developed the platformer, or a faculty member here who developed the platform called D3. And he developed this at Stanford, but he's now here at UW. And it is this awesome platform that lets you do all kinds of things. And he has a class of students that I've enlisted several of to come help create prototypes of visualizations for our new tool. And so this one, and I got to give Jacob a shout out. I just met with him this morning, and he showed me this is one of our clinics, okay? And it's not pretty quite yet up here, but basically, the dots here are how many years a patient's been seen within that clinic, okay? So you can see these are all the patients. There's 911 of these guys that have been seen in this one clinic over the span of the EHR. What he's done, so if I want to group it by color, I can start to color code. Now you can see how many are men and how many are women. And so just to solidify that, right, and then you can see the dots. This is what visualization is about, where you can kind of start to spread things around. If I'm interested in disparities like I am, I want to know race and say, tell me how is that divided across. If I want to look at race and I want to color code it in that way, and then go to ethnicity and say, look at the Hispanic and non-Hispanic. Or better yet, I'm only interested in, let's say, older adults. What's your population look like when it comes to age? And so I want to show this to you to just kind of inspire some of what's coming down the pike. We all are dealing with these kind of visualizations all the time when you're going online and shopping for things. When you buy a car, for anyone who's lucky enough to go buy a car at a dealership, and you can go online and pick all your options, right? You're dealing with visualizations on a daily basis. So this is the kind of stuff that we're trying to build in to what we've got. So let me pull these back up, right? So I want to kind of just bring us back as we close, and then hopefully if anyone has questions, you'll have a little time to ask questions. But, you know, in behavioral health care, you know, here's my son's Legos again, right? You know, I want us to be dreaming. I want to try to inspire you all today to be dreaming about what could we do. You know, could we predict weather? You know, right now with big data, right, many of you probably heard about Google and how they were predicting flu epidemic. And then that turned, and then it wasn't predicted, right? But they were looking at Twitter data, and they were actually able to go vaccinate and prevent a lot of flu. Cheap flights, like for any of you who have used kayak.com, I think one of the things that's so fascinating to me is you go to kayak.com, they don't have partnerships with Priceline and all the other airline arenas. They just go to their websites, pull the data right off them, and then reorganize it in the way they want for you. So there was no governance there involved whatsoever, and there's nothing Priceline can do about it, right? So what if we did that in healthcare? You know, and I don't want to be too scary, but, you know, in the EHR, if you go to a patient's, you know, page, I do this every week when I'm reviewing my patient charts, and it's a pain. But what if I did this and I was able to look at my colleague, Judy Turner, and my other colleague, Michelle Bedard-Gilligan, and I could look at who are all the patients we all have seen in our clinic in the last 12 months and who's referring them to us, and we could instantly get visualizations on these kinds of things, right? We need to work around this kind of old, antiquated notion that I've just spent all this time talking to you about, which is about putting all the data in the same place centrally, right? There's going to be other ways we do this. There are ways that they're predicting fire hazards in New York, you know, where they've got limited resources. It is very, that same issue is the same for us. If you only can do checks on 300 buildings a year in New York City, you want to make sure you're checking the ones that actually are high risk for fire hazard, right? So they've used big data to do that, and now they have about 70 that are out of compliance, 70% that are out of compliance instead of 20% when they're randomly hitting them. We have behavioral health specialists that cannot touch every single patient in the clinic. So how do we use that resource in a really smart way and use the data to guide that and tell us where we're going to have the biggest hit? You know, global mood patterns are now, you know, they're substantiating depression is in fact a totally non-culturally specific issue because they can look big data wise and see it happening everywhere. And then right down, I love the nature of the cosmos. It's fascinating to me because also right here, folks involved with the eScience Institute are helping with the new telescope that's going to replace Hubble and will be helping with the transmission of all those data to Earth, right? So, I mean, even when we go out to the cosmos, we're figuring this stuff out together. So, you know, I want to challenge you guys and figure out what could we do? You know, and one of the things, one way to think about that is when you look at this pile of Legos is what other Legos do we need to add to that pile, right? I think that as behavioral mental health people, we know there's a bunch of data that they don't have out in these systems, and we need to figure out what those are, and we need to make sure that they're part of this big picture of all these data. Okay. So, you know, this really is the tip of the iceberg is what I'm talking about. There are so many other things coming forward right now that are going to be moving and pushing us far ahead. Part of it's the cloud, you know, where we're storing things. Part of it's these wearables everywhere. I don't know how many of you have them on your wrists right now, but, you know, doing this kind of quantified self idea where we are deciding to track everything about ourselves and figure out who we are. 23andMe, where you can get your genomics completely mapped and figured out. Consumer data clouds, right, and how we buy things and how that also is very telling for how we're living. You know, and then I think many of us saw Pat Arian's talk, you know, in the kind of neurocognitive exciting things that are going on of ways we can measure memory and perception and ways that we can be diagnosing people that we haven't even dreamed of. So I think we need to be thinking really about what's missing in this space and get excited about thinking about how we can start to involve these data in our daily lives. And so whether you're a clinician who doesn't do research, you're a data creator and you're putting it all in there. Let's think about that. I hate charting. I'm with you on that. But thinking about the fact that, you know, what we do, if we standardize ways we actually chart on these things, we'll have those data to do these kind of exciting things for, you know, all the way to the research. So I think I'm going to stop there and see if anybody has questions. So thanks for listening.
The machine learning and e-science, that sounds fascinating. What kind of algorithms do they use?
So he's asking in machine learning and the eScience Institute, what kind of algorithms do they use? And I'm remembering to repeat for our folks that aren't here, which I'm usually one of and hate when I can't hear the question. So That's a really big question. There's all kinds of machine learning algorithms being used in all different kinds of ways. The way that I'll try to answer that a little bit is to say, one of the things the eScience Institute is really interested in doing is crossing disciplines and saying, you know, the kind of machine learning that astronomy needs isn't all that different from what oceanography needs, isn't all that different from what we need in health. And so can we be building these algorithms together and say, here's a thing. You know, there are many different groups, for example, that have thousands of Excel spreadsheets. And now what? How do I get all these combined? So they're really interested right now in building tools, and they're looking for use cases, is kind of what we call them. They're looking for people to come forward and say, here's my problem, can you fix it? And is it a problem that might be scalable to other disciplines? And can they help you along with finding that solution? Dave Atkins is someone in our department, if you're interested in machine learning, who's getting deeper into that. And I don't think it was in here, but I meant to have this in here, you know, that Jürgen's asked us to start a new program on behavioral health and technology, behavioral science and technology. So I'm working with Dave to create this new program. And, you know, machine learning will certainly be a part of it along with all these other technologies. Yeah. Yeah.
I just keep thinking about the data that comes in from clinical systems and how limited I imagine that is, especially in behavioral health. So I guess I mean, because clinicians are busy and people are complicated, you get a lot of NLS diagnoses, and I wonder about the challenges you encounter with trying to get meaningful data out of clinical notes.
Yeah, so the question is, the data, and hopefully I'll paraphrase this in a way you feel okay with, but basically the data are very messy and very limited. And that the clinicians, you're very busy, and the quality of the data that's going in is to some degree questionable or not granular enough for what we need, or appropriate even with the right information. And so you're asking kind of what
Well,
what we can do with that.
How do you deal with that? Like, you know, at Harvard U we have many patients who you can't really give conclusive diagnoses to because there's substance use and there's all kinds of stuff, and so if you want to be able to make assumptions about what we're looking at with this population,
right,
it seems very difficult.
Yeah, this is a conversation. So you're saying I'm just repeating again. You know, that it's very difficult to know what you're looking at when it's so hard, just even in the clinical interaction, to make good diagnoses, let alone what's actually tracked in the EHR. And so for me, that goes back to data provenance. You know, this which is again this fancy term for where did the data really come from? What's the origin of these? And then what can we do? So this is a conversation Patrick Haggerty in Biostats and I have all the time, where he's going, you know, is this really, what can you say about this? And so I think that, you know, with DataQuest, part of what we have is a coordinating center where we do a lot of that consultation with the researchers, because it's hard to know that, and we're figuring it out as we go. Like even in primary care, when you're trying to figure out, have you had a primary care visit? That sounds really straightforward, but it's actually not. And the way that's stored in the data, who exactly did you see, and does your primary care doc sending you an e-care message count? Does that count as a visit? And it's all tracked in different ways in the system. And so how do you know that? So I think that, you know, the data are very, very messy and to some degree primitive. But on the other hand, there's very real information in there that can be incredibly helpful. And if we look at it, again, you know, taking a page out of the big data space in this fourth paradigm sort of idea, big data is correlational. It's not causal. And that's the big problem, I think, that people are trying to put in there when you're looking at it from an epidemiologic standpoint and saying, I want to say this is the prevalence of that disease. You know, we can't know that. You know, we don't even have the right diagnostic tools, let alone digitized, you know, to tell us that. So we need to be thinking about correlation. We need to be thinking about, well, what can they tell us that's meaningful to me? Like if I want to look at a patient and say, how engaged is this patient? How many medications do they have? How many diagnoses do they have? How many touches have they had in the last 6 months? I can guarantee you every single patient I see every week, I'm looking at that pattern. I need the data to tell me that. And what would that tell me? Would that tell me something about these complex patients that have comorbid mental illness, substance use, and physical illness? Maybe. You know, utilization information is going to help us understand that. So I think we need to be thinking a little more outside the box instead of demanding the data be of a certain way. Let's look at what's there and then figure out what it can do for us. And then let's figure out how we can make it better. Yeah, Ty.
So, great presentation. It's fascinating stuff, and I trust you because I know you quite well.
the flip side of this, and there was even a recent New York Times article, is that they're give over data and they're not happy about it, but they don't feel like there's any way they control it or have any control over data. So and we've been discussing like open notes and having those kind of services. Now, what is being done to also protect the data or have people the ability to control their own data? So what's being used on me is at least what I want you to use.
Yeah, it's a great question. So you're asking about privacy and how does this fit into it, and people that are feeling like I don't want my data shared with everybody, or how do I control that, and how does that happen? So I may scare you some more and tell you that electronic health record companies sell their data, sell all of our data already, and they sell it anonymized to big pharma and to whoever's going to pay them for it, and they don't tell you that, and by law they don't have to. Honestly. And so some of this, it's kind of this delicate balance. We're in mental health, so our data can get really, really tricky. We were just having a discussion in clinic about should we put patient history in fully, because what if it has a bunch of trauma detail or substance history that you feel like your patient's going to get discriminated against if their other providers know that? Or, do we go toe the line of saying, we need to destigmatize this and put it out there. These are complicated. This is why we have a bioethicist in our group. Questions, really complicated questions, and there isn't a great answer. And that's actually a big part of why the tribes are going, whoa, wait a minute. So I don't have a much better answer for you, Ty, except that we've got to figure it out. And I also think it's good for us to be not hindered by the fear of that privacy kind of stuff, because the kinds of things we could do if we sort of open that up would be tremendous. And this country's already been massively hindered by that privacy stuff. Yeah.
How much of this information is available to your insurance?
So the question is, how much of this information is available to your insurance? The electronic health record systems truly originate as billing systems. And that is primarily what they are. We have evolved them to some degree to be clinically helpful to us, although I will also put helpful in quotes. There is data that is shipped from them directly to the insurance companies, and then they generate those into claims data of what they actually reimburse, which is a whole nother set of kind of transforming of information. So insurance companies typically don't get notes. They don't typically get narratives of things that are in there, but they do get things that are going to imply some kind of billing. So diagnosis codes that are telling you about what you were treating, severity of those kinds of things, time, that you spent during those visits, procedures, and these things get coded into what we call ontologies, things like CPT codes and ICD-9 codes and things, so that the billing companies know what to reimburse for. Yeah.
So this is great. And the research side of me gets very excited during all this. It reminds me that as a clinician, I have been sort of constantly frustrated by how hard it is to track my own outcomes and say compare them to the person sitting next to me or the hospital at large. I had this fantasy coming into this. I was terribly naive, but I'd be able to just, look as I progress through residency and fellowship of like, how have outcomes for all my depression patients changed? How many patients fall off the radar? Just as sort of like this local clinician, is any of this headed in that direction? Like the quest portion, would this be doable for non-researchers who just want to track?
Yeah, so the question is, what about for clinicians who just want to be able to track kind of patient population within themselves of who they're seeing. And I think absolutely that is the direction we're going. I've heard Jürgen actually talk about wanting to get regular outcomes on patients and evaluate everyone, in terms of not us as clinicians, but evaluate everyone in terms of the patients and finding out who's getting better and how quickly are they getting better and what parts of our system of care are working and what parts aren't. So I absolutely agree with you. The way that I appease myself with that, the fact that we don't have those tools yet, is I track an Excel spreadsheet of all my patients and go through it. And it inspires me to think about, what are some tools we can do to bring this stuff forward. I also think one of the things I've been talking with some other folks about is predictive analytics around that, for patient engagement too. If you could also put it patient facing and say, here's, I keep thinking about this problem of our farmers we've got rurally located, and these men who have worked their whole lives and they get depressed and they don't want to come in for treatment. And no, I don't need that stuff. Yet if you tell them, here's your heart risk, I better do something about that. I better work on my blood pressure, right? Can't we put this kind of information in front of them too and say, if you don't come in and get seen, and here's this doctor and here's what her patients have done and here's how they look when they go see her, right? maybe that would engage those guys. We have huge disparities in gender for this kind of care where men just don't want to come in for treatment, right? So absolutely, we need to move that way, and we need people like you helping us think about it. Okay? Yeah?
Are there any ways to be able to standardize what people are putting into these big data sets? Like if you're measuring something like impulsivity and people are measuring it 8,000 different ways, how can you really be able to get that big end to make some big conclusions?
Yeah, that's a great question. So she's asking, how do you standardize all of these different kinds of data that can come in? People can collect them in all different ways. So even if you look at something that sounds simple like diagnosis codes, those have gotten more standardized because the insurance companies have demanded it. But in terms of services, procedures, things that are happening in the clinics, there are codes. Actually, great example, labs. There's a whole ontology for labs. Nobody uses it. Everybody uses proprietary lab codes. Drives us crazy. So part of the big issue is incentive. There is no incentive for all these different groups to band together and do things in the same way. But I think that the good news of this is that things are revolutionizing in healthcare right now, and for the first time ever, with healthcare reform, there is incentive being placed there. In fact, one of the meaningful use criteria is now demanding that electronic health record systems have to be able to not just put out data in a standard way, but they have to take it in. And now they're going, oh no. So we better actually be storing it the right way so we can do that. And we're all going, thank you. It's about time. So I think in behavioral health, what you're bringing, you gave an example of impulsivity. And that's one of those Lego pieces that's missing. How do we think of that as an entire field to standardize the kind of behavioral metrics that we need to have? It's a good question. Yeah. So I think we're about out of time. So thank you all for coming.